or the Roadmap Scholar Program or Professional Development Corps is, I'm not going to tell you. Go to our website and have a look. I'm here to introduce our guest speaker, who's actually been our visiting expert here to guide us in our research endeavors, and he's a very appropriate person to do that. He's Dr. Paul Conlin. He's the chief of the medical service at the VA in Boston, professor of medicine at Harvard Medical School. He's an endocrinologist who's an expert in diabetes. He's done a lot of health service research using the VA database. He's also done work on tele-imaging of the retina for the VA, introducing it on a large scale, and has been working on things like the VA guidelines for diabetes, managing diabetes in older people, which is a very important topic for the VA, and also about hemoglobin A1c, which he's going to talk to us about HbA1c variability. Welcome, Paul. We have a lot of people online because this is LSU and also Tulane Grand Rounds today. So when you're asking questions, we might pass the microphone, or we'll ask Paul, or I'll come and repeat the question at that time.
Understood. Okay. I have the lavalier mic, so I guess that gives me a little bit ability to roam. Is this microphone also active? Okay. Okay, wonderful. Dr. Fonseca, thank you so much for the kind introduction to you and your colleague, Dr. Kerwin, from the LA CaTS program. It's been such a pleasure to be here this morning to hear about such great work that these early career investigators are conducting. And I'll put in a little extra plug for the program. Those of you who have an interest in discovery in clinical translational research, go to the website or talk to Dr. Fonseca or Dr. Kerwin after today's meeting. So it's so important. And I was told to scroll through a couple of slides. Actually, okay. Did I go too far? Or is that the first slide? Okay. So this is about the accreditation and the disclosures. That there was a disclosure for Dr. Fonseca, but that's been mitigated. Okay. And there we go. Okay. And I had actually embedded in my slides my own disclosures, which I have none, regarding the topic that I'm going to speak about today. I'm not going to talk about any medications or off-label indications. I've been fortunate to have research funding to underwrite a lot of the work that I'm going to present today. And I am a federal employee, so I'm going to give you a little disclaimer that nothing that I say has the blessing of my federal partners. Not that I'm going to necessarily stray too far. The objectives for today's presentation are, I'm going to talk about guideline-directed care, diabetes care for older adults, and how there is a role for individualization. Hopefully, at the end, you'll understand that potential overtreatment is real and has consequences, and that I'm going to present to you some interesting findings that you may not have thought about, and that is how patterns of A1C trends over time may actually reveal risk prediction information, particularly with regard to major adverse events. And the focus of my talk is largely going to be on older adults, where most of our data derives. For those of you who are clinicians, I bring you back to Sir William Osler and the value of curiosity and remaining up to date. And if you just indulge me, I'll read this. In our minds, countless oft-repeated experiences wear similar ruts in which we find it easiest to travel, and out of which many of us never dream of straying. Year by year, we follow the same plan and practice, give the same drugs, and settle down into routines of the most commonplace type. The profession has suffered so sorely from a blight of intellectual old fogeyism. Would you know the signs? First, a state of blissful happiness and contentment with things as they are. Secondly, a conviction that the condition of other people and institutions is one of pitiable inferiority. And thirdly, a fear of change that both perplexes and appalls. So this charge, which was 125 years ago, is still current today. So this is a call to curiosity, both young and old alike. And thank you for coming and being curious. So I'm going to talk about practice guidelines and what they recommend, particularly for older adults, and how they're balancing the benefits versus the burdens. How does diabetes treatment per se affect mortality, and the fact that potential overtreatment in older adults is real and has consequences. And then towards the end of my talk, I'll present some data about how patterns of A1C over time may actually carry risk prediction information. So let me start out by briefly talking about the burdens and the benefits, particularly in older adults. And I think most of you are aware of this. Ronald Reagan was famous for his quips. I give you this one. You can take a second and read it. So we tend to think of age as degrading our abilities. And as a result of that, we oftentimes relax treatment or maybe alter treatment. But age is now a spectrum. And as many of us approach some of those ages that used to be called elderly, it has much more relevance. With regard to diabetes care, when you look at glucose lowering per se, and I'm not going to be focusing much of my talk today about some of the other aspects of diabetes care involving cardiovascular risk reduction through specific medications, that it turns out that with few exceptions, there are no short-term benefits to glucose lowering until someone has been treated for at least 10 years or longer. This was shown at least in a signal in the VA diabetes trial, and then recently in the 25-year follow-up of a very long held study called the United Kingdom Prospective Diabetes Study. But for the most part, when people have diabetes and you treat them for glucose lowering over 5 to 10 years, you actually have very little effect on their mortality or cardiovascular disease. You might actually affect their renal disease or neuropathy or retinopathy. But in terms of prolonging life, that's not going to be what's going to get people longer life expectancy. And practice guidelines as a result of that really do suggest that individualizing glucose control is really important because of the impacts that may be accrued both over short as well as long term, driven by what the person's likelihood of benefiting is. Clinicians in general, myself included, are very poor at predicting whether or not a person will survive for extended periods of time, particularly as people get older. And patients oftentimes have unrealistic expectations. The shared decision-making balance, particularly in older adults, involves focusing on what are the benefits to the patient in terms of complications, and what are the risks, particularly with regard to the treatment that you're going to implement and what consequences it may have. So, for example, questions that you may pose to patients are, what are the treatment goals that you think are appropriate? What does the patient want? What are they willing or able to do? What outcomes are they hoping for? And then on the consequences or costs, I put in quotation marks, is what are the things that you're going to impose upon them that may affect their decision to stay with whatever your goals are set for them. The role, polypharmacy, the consequences of that, the risk for hypoglycemia, particularly when using medications that may carry that risk, frequent healthcare visits, healthcare utilization, and other consequences. And it turns out that patients have very unique perspectives on this, and some that aren't necessarily aligned with what we as clinicians would think are appropriate. I like to cite this study, which was actually a survey of a bunch of patients with diabetes, older adults, that over 800 individuals, you can see the mean age was 74 years, and they were asked about the importance of several factors that may influence a shared decision-making about either starting or stopping diabetes medications. And they were asked for their what were influential factors in whether or not treatment would be intensified or not. And you could see the fundamental question in this survey was, which hypothetical patient, which was presented, should have more aggressive treatment for diabetes? And shown in the right-hand slide, right-hand portion of the slide, is 3 characteristics. Diabetes duration as a criterion for aggressiveness. Note that 60% of this group of older adults said that a person who's had diabetes for 15 years should be treated aggressively in comparison to someone who has diabetes for 5 years. Now, that may not necessarily be the most appropriate approach. And then the question about a person who has established complications. 75% said that a person who has severe complications should be treated aggressively, and fewer if they have no complications. In fact, it's the latter that would derive more benefit. And maybe patients were a bit more aligned with the concept of life expectancy, with agreeing that someone who will live greater than 15 years would probably benefit from more aggressive treatment. But the dissonance in this is something that we have to wrestle with when we're making shared decision-making decisions with patients, because in fact, their expectations and ours may be very different. But there are consequences to treatment as well. These are data that are about 10 years old, but they show the differences in hospitalizations for hyperglycemia versus hypoglycemia in Medicare eligible, generally people over the age of 65. Now, this was an era when the panoply of medications was not as broad as we have now, but notice that the frequency of hyperglycemia as a cause for hospitalization was shrinking dramatically and reached a nadir in approximately 2006 to 2007, whereas the hospitalizations for hypoglycemia remained relatively high. So that now hypoglycemia was much more common than hyperglycemia. And also note that if you were hospitalized for hypoglycemia, you had a 20% likelihood of dying within the next year. Now, you could argue that maybe hypoglycemia is a marker of frailty or other comorbidities, but whether it be cause and effect or association, it's certainly something not to be ignored. So let me talk about what do our professional societies and guideline committees say about treating patients with who are older adults with diabetes with regard to their glucose control. And there are a variety of different guidelines, different professional societies coming to somewhat different conclusions, although there's somewhat of a harmonization. And what I want you to take from this, and I'll show you one additional slide, is that as you can see, the characteristics and the goals, patient characteristics and the goals can differ. Whereas people who have longer life expectancy and are otherwise healthy, that A1c goals may be appropriate to be, say, for example, less than 7. That those who are older adults who carry comorbidities or other health consequences should be looked at individually. There is no one size fits all. So you can see the American Diabetes Association breaks people down into healthy or complex medical needs or very complex. The American Geriatric Society also somewhat similarly breaks down people into different categories of health status. And the Endocrine Society, not surprisingly, also has a very similar type of framework. Also note that some of the guideline societies or committees have actually proposed target ranges for A1c, which brings into discussion the idea that whereas previously we used to think that upper limits were the most important, lowering is what's most valuable, that perhaps there is some merit to considering that too low is also consequential. Now, the American Diabetes Association hadn't quite embraced that, and I think that's an opportunity for reevaluating. But the idea is that sometimes lower A1c is going to be of greater consequence than higher A1c. And I was fortunate to be part of the development committee for the VA Department of Defense guidelines, which not surprisingly had very similar approaches, looking at people based on life expectancy, comorbidities, and complications with, again, different A1c target ranges. But you can also see that the target ranges are bounded by upper and lower limits, with the idea that there is a benefit to reducing hyperglycemia, but also potential consequences that should be considered when you get too low. And we're going to come back to this later because it formed the basis for some of the research that we did looking at people's time spent in each one of these ranges by the nature of their ongoing care. We tend to get caught up in dichotomous thinking with regard to glucose management in patients with diabetes. And some of it is driven by external entities, promulgate quality measures. And there's this good, bad thinking that, if your A1C is 7.9, then maybe you're okay, based on HEDIS measures. But if you're 8.1, that somehow that's bad. That kind of thinking, particularly among older adults, is flawed. There are two reasons for that. One is that if you do an A1C measurement on somebody today and then do it again tomorrow and do it again on the next day, the variance in the assay for most even well validated assays is going to be 0.2 to 0.3. That's the intra-assay variability, and inter-assay variability is maybe a little bit higher. So as a result of that, individualization is really very critical. That it's important to think about people as having a continuum of risk, but also a continuum of benefit. What do we know about the relationship between A1C levels and mortality? And I'm focusing on mortality because that's really a hard and fast outcome. Other outcomes with regard to cardiovascular disease, renal disease, tangible, but mortality is something that you can actually count, and it obviously has significant consequences. So this is a study that was published in The Lancet now about 15 years ago, but it was a study in which individuals, older adults, were considered targets for intensification of treatment by their clinicians. And they received either oral medications for diabetes management or insulin. And this was obviously uncontrolled and observational. And the investigators looked at, over the course of, on average, about 4.5 years, what was the mortality of these individuals over time based upon what their average A1C was during this period following intensification. And what was found was that there is a nonlinear U-shaped relationship between mean A1C and mortality. You can see the average age of the individuals is 64 years. And that as your A1C gets lower, there's actually an uptick. Now you can see that there's a more marked rise in the curve in the patients treated with insulin. And obviously the initial speculation is, oh, it's all driven by hypoglycemia, which is a reasonable and testable hypothesis. But I think it's important to understand that that observation is real, and it may or may not be related to hypoglycemia occurrences. The other thing you'll notice is that in the data points, you'll see that there are error bars going both vertically as well as horizontally. The horizontal representing the A1C variability of the individuals around that data point. You can also notice that as people's A1Cs were either higher or lower, the variability around those A1Cs tended to increase, which was a little bit of a clue that some of this may not be solely based on mean A1C, but other factors associated with blood sugar control. This phenomenon of a U-shaped relationship has been observed in a variety of other observational studies. I've shown you just 2 studies here, both of which are older adults, one involving over 70,000 individuals, 71 years of age, 4 years of follow-up, a smaller study involving about 3,000 individuals, but very similar findings, that there is this lower limit, and it varies based on the study, where below which mortality is increased and above which mortality is increased, making the perception that there's actually a kind of a, pardon the pun, a sweet spot that you need to be when you have diabetes, particularly among older adults. And similar findings were observed in randomized clinical trials that were subsequently analyzed with hypothesis-generating analyses. So let me now talk a bit about this concept of glucose variability and what impact it may have in both the acute as well as in the chronic setting. With regard to relatively acute glucose variability, everyone is either has or is gaining experience with use of continuous glucose monitors. And obviously a major advance in technology. Currently, at least in most insurance environments, they're usually available to people who are treated with insulin, Many of the companies are now coming out with devices that people can use without prescriptions or can access via other means. So they're growing, and this whole concept of wearables for a variety of different factors is becoming quite popular. The data with CGMs is still growing, and I think this is an area where we have to be both excited as well as cautious. And the reason I say that is because the excited part is what potential may lie ahead. The cautious is some of that gain has yet to be realized. So there is reasonably good evidence that CGM use in randomized clinical trials will lower A1C with, on average, about a delta of between 0.4 and 0.6%, typically in individuals that have hyperglycemia, and you'll see that subsequently. There is moderate quality evidence that reducing use of a CGM will reduce the frequency of hypoglycemia, and there's lower quality evidence that it actually reduces hyperglycemia. This is an evolving field, but at least this is what is published. There is some evidence that, in fact, CGM use is beneficial for reducing hospitalizations for acute care, ED visits, and hospitalizations for severe hypoglycemia over a 12-month period. Most of these studies, in fact, almost all of them, have been done in insulin-requiring patients who are not at goal, meaning to say that typically they have elevated A1C. There are fewer studies that have been done in people who are actually at a goal level to know whether or not, in fact, it impacts on their quality of care or in their outcomes. And there really are, I'm not aware of any significant cost-effectiveness studies. So CGM is growing dramatically, but there's still a lot of questions about where it fits in. And then particularly among older adults, there's at least some tendency to embrace the use of CGM, but there's also some reluctance because of the fact that not everyone is ready to begin using technology. There's unclear benefits to whether or not having a device alert you as your glucose is going down, and that might avert a hypoglycemic event, whether or not that actually has outcome consequences. And as I mentioned, there's really not a lot of data in older adults with the use of somebody maybe unmuted. Okay. Some of you may have familiarity with such data reports. This is a patient of mine that one would possibly argue is doing reasonably well. This is an insulin-treated patient with diabetes who, you can see has an average glucose of 150, a glucose management indicator of 6.9, basically the CGM equivalent of an A1C. And you can see that their variability through the day is reasonable and probably not in need of a lot of attention. And then you can see this patient, who is somebody I recently saw, who maybe has a little bit more of a challenge with hyperglycemia. This is a man who's in his late 70s, using a CGM also on insulin. Now, the intriguing thing about this report, and those of you who have familiarity with them, it's 12 pages long. This is the front page. And for those of you who actually take the time to look at those reports, they can be rich in data, but they can also be overloading with data. If you look at this summary, you'd say this gentleman is hyperglycemic, but if you look at the line, or the kind of the gray connecting line that goes throughout the 24-hour interval, you'd say that, well, he's high, but he's reasonably stably high. Buried on page 11 of the report is one of the days in which we have CGM results, and it looks very, very different from the mean. And one of the challenges with CGM is that you get so much data. How do you know how to act on it? Like, granted, this would be troubling to me, but it certainly doesn't reflect the mean. And I'm not necessarily sure what I'm going to do with that information. Obviously, I'm going to be looking for reasons why this person had such low readings and then such high readings. But the mean doesn't necessarily always reflect what's going on in the day-to-day. So CGMs are wonderful devices, and they can give you information about day-to-day glucose variability, but there's a lot of potential for data overload. I'm going to now talk more about longer-term glucose control, which is the area in which we have so much more data, in which there is so much more evidence base. And I'm going to focus on A1C patterns and how they may be able to provide us with some risk prediction information. So Mark Twain, famous author of the Tales of Huckleberry Finn, is certainly one to talk about the journey, teaching us about the destination. This is a patient I've had the pleasure of caring for many years. You can see we have A1C values going back to 1992. I was not involved in his care through the duration of this, nor do I take any responsibility for what has happened over the course of his lifetime of insulin-requiring diabetes. But what you can see is that this is a gentleman who has had A1Cs over the course of the last 30 years plus that have varied by small amounts. Yes, there's some movement in the upward and as well as the downward direction. But he's been so fortunate to develop retinopathy and nothing else. So he's in his late 60s. He has no kidney disease. He's not had any heart disease. He does not have neuropathy. Now contrast that with this gentleman who's in his mid-70s, who I've also cared for. And although, albeit over a shorter period of time, you can see the swings in his A1Cs over time. And the arrows point out various points in time when things occurred. You can see developed microalbuminuria, peripheral vascular disease. There's a line that's kind of long in the middle there. Actually, that represents a hiatus where we didn't see him, where he just kind of dropped out. So, we have no idea what his A1C was doing during that interval. He then had coronary disease, recently a stroke. You can see he started a CGM and had a great decline in his A1C, only to have it climb back up again. So very different patterns and very different outcomes. And this is a case where, is there something in there that provides us with some reason to believe we can explain these two different outcomes? And I like Roger Price, who is famous for these thought-provoking drawings. As you can see, it depends on your perspective. And so what I'd like to give you is a little bit of perspective. And that is there something about the variability of these two individuals that underlies their differences in outcomes? And that's what I'm going to share with you now. There is a clear and established legacy effect from control of glucose over time. This was first shown in the Diabetes Control and Complications trial, which was a study of type 1 diabetes, where intensive versus standard care was done, clearly showing benefits in microvascular complications such as retinopathy, neuropathy, and nephropathy. But then as people were followed over time, even when their A1Cs climbed after discontinuation of the trial, that there was a benefit that persisted over time. Similar things were present in the United Kingdom prospective diabetes trial, which again was a new diagnosis of type 2 diabetes followed over many years with intensive versus standard of care. If you look, though, at what the impact of the mean A1C is on that legacy effect, it's about 11%. So there is some effect of this early period of control and longer-term effects on outcomes, particularly with regard to retinopathy risk. There have been several studies that I'll describe briefly that have looked at what is the role of variability of A1C over time as a risk predictor. Now, is there plausibility that variability of a biologic variable could actually have consequences? In fact, there's actually a very rich literature on heart rate variability and cardiovascular outcomes. There is a growing literature on blood pressure variability, visit-to-visit blood pressure variability, and even visit-to-visit weight variability as a marker of cardiovascular disease risk. So this concept that a biologic variable that has heterogeneity over time might have consequences is actually borne out in a variety of other domains. Going back to the diabetes control and complications trial that I just described, again, a study of type 1 diabetes randomized to either intensive or standard of care, that there was an increase in the frequency of retinopathy and nephropathy based upon those individuals who had higher glycemic variability. And what you see in the right-hand portion of the slide is the hazard ratio, or the relative risk, I should say, in the upper portion of the graphs of what the actual A1C, mean A1C was. Higher A1C was associated with higher risk. But then in the bottom graph on the right, you see what was the risk associated with the percentile of individuals broken down by A1C variability. And you can see that those who had the greatest A1C variability had the greatest risk of complications. And that was independent of what their mean A1C was. The hazard ratios, you can see, were approaching 2 in most cases. So in type 1 diabetes, in an intensively treated population, high A1C variability was associated with adverse consequences. In a study that was done in the UK by Forbes and Sinclair, also in older adults in this case, showed a similar type of finding. Shown in the right-hand portion of the slide in the upper graph is actually the mean A1C of this population that was followed over about 4 years. And what they found was, and without getting into the details, they used 3 different models for how they analyzed the mean A1C, varying the types of variables that were controlled for. But they also found a U-shaped relationship, or at least a J-shaped relationship, in which the risk for mortality was increased as people's A1C, mean A1C was lower. But then in the lower graph, they created an A1C change score, which basically was how often did the individual have a change in their A1C by about 0.5%. So going from 7 to 7.5 or greater. And so more change scores meant more variability over time. And what they found was people who had more of those change scores, more variability, also had higher mortality. So they found both the U-shaped relationship as well as the increase in variability as a risk predictor for mortality among older adults. And this was actually captured in a meta-analysis that was published about 10 years ago, where there were a series of studies that looked at glycemic variability and risk for outcomes. And that included not only mortality, but also cardiovascular, nephropathy, retinopathy outcomes. And what you can see is that higher A1C variability by any one of a number of measures, whether it be standard deviation, coefficient of variation, or these change scores, was associated with increased risk for kidney disease, cardiovascular disease, and mortality. And in each instance, this was independent of mean A1C, and at least by these authors, perhaps a better predictor of risk as a consequence. This was also shown in the ACCORD trial and the VA diabetes trial, 2 randomized clinical trials in which patients were assigned to either intensive versus standard therapy in type 2 diabetes, this time looking at fasting glucose. So these investigators looked at that as a measure of glucose variability, and they similarly found that as your fasting glucose variability increased, so did your risk for microvascular complications. So it looks like there's something there. The association of this stability of glucose control over time, though, is potentially confounded by, is it really related to the variability, or is it really the average, or is it both? And hopefully I've shown you data that there is this nonlinear relationship between A1C and adverse events, particularly in older adults. That variability, at least as best we can tell, predicts complications, in many cases independent of mean A1C. That there appears to be lower risks for A1C levels when they kind of fall in that area of the curve of 7 to 8.5%. And that's probably why the guidelines support that in terms of target for patients that are older adults. The practice guidelines support this individualization. So the question that we posed is, does more time spent in those target ranges make a difference in terms of clinical outcomes in patients that are older adults? And so now I'm going to talk to you about what we have termed A1C time in range. And I want to be very cautious that the term time in range has been applied very frequently to glucose time in range, which is part of a CGM report. We're taking the same concept of we've defined an upper and a lower bound, we've defined time intervals, and we're now talking about how much of the person's time is spent in that. So now we're talking about longer term, and I'll show you how this is measured. The first thing we needed to do was to say, can we define target ranges in a population? And using population health data, we were challenged by the fact that, and this is the table that I showed you earlier from the VA DoD guidelines, which includes upper and lower bounds. How do you define what someone's life expectancy would be, what their comorbidity burden is, and what their complications are as pre-existing conditions that might dictate what their appropriate target would be? And so we actually developed a life expectancy calculator in over 400,000 older adults, veterans. And we could determine from that if an individual with reasonably good accuracy, whether they had less than 5 years, 5 to 10 years, or greater than 10 years of life expectancy. And then we used a published and validated instrument called the Diabetes Complication Severity Index, which through ICD-9 or ICD-10 codes captures a variety of diagnoses that would be relevant in setting whether or not the person has a substantial or more modest comorbidity burden. And we applied this to VA and Medicare data and to a population of patients, older adults with diabetes, to see, could we actually assign people to different categories? And we were able to do so. And so what you can see here across the top, among individuals with greater than 10 years of life expectancy, we could assign them to different target ranges. You can see that the majority of people fell into that category of greater than 10 years of life expectancy, and all the way down to the bottom where there are a few individuals who have less than 5 years of life expectancy and therefore would potentially have higher A1C targets for their longer term goals because their life expectancy is shorter, and so we might consider that to be more modest. And then what we did was we said, okay, if we can assign someone to a target range, can we then look backwards and say, what were their A1C values during a 3-year period, and how often did they spend time in their assigned target range? And just as a graphic, and borrowing a little bit of the color schema that's used in CGM reports, this schema shows a hypothetical patient who has hemoglobin A1C values over the course of about 3 years. And the grayed area represents the target range that we have determined for them based upon their life expectancy and comorbidities. And what you can do is basically by linear interpolation, determine how much time they spent in that target range. And shown here is that this individual spent a little bit more than 2/3 of their time in their target range. And so now what impact might that have on the association of that with outcomes? And in another separate sample, almost 400,000, again, veterans with diabetes, older adults, 74 years, who had a median of 6 A1C tests over the course of 3 years with a minimum of 4, so that we had enough to be able to determine time in range. and applying some advanced statistical techniques using an instrumental variable, which in essence provides a quasi-experimental approach and allows you to account for lots of unmeasured confounding. What we found was that over a median follow-up of 5.5 years, that the less time you spent in your target range, the greater was your risk for mortality, cardiovascular disease, or a composite of microvascular diseases, which we defined as nephropathy, retinopathy, and neuropathy. Again, using the Diabetes Complication Severity Index as a tool. And you can see that the people who were at the greatest risk were those who spent less than 20% of their time in range. This just shows a Kaplan-Meier plot of the breakdown of mortality as a function of time in range. And it shows the graded relationship of greater or lesser time in range and mortality. And I point out to you, although not specifically designed for this purpose, but if you look at the point of 50% mortality, the group that had the 0 to 20% time in range had a 50% mortality at about 6 years. And the group that had the highest time in range, 80 to 100%, actually their 50% mortality was about 10 years. So it really does look like there's a separation between the two. Keeping in mind that these are associations and not necessarily causations, despite the fact that we're using some quasi-experimental techniques. We wanted to validate whether or not these findings may be generalizable. And so we partnered with some colleagues at Kaiser Permanente and were able to obtain a sample of about 25,000 older adults from KP. Again, 72 years, similar criteria of A1C numbers in order to be able to calculate time in range, same techniques of controlling for a variety of variables, and including using the instrumental variable, and similar findings. The one difference is that the microvascular complication risk was a bit more noisy, but mortality and cardiovascular disease, 20 to 30% increased risk with lower time in range. So this does lead us to believe that there's something there about A1C variability as defined by time in range. And maybe not surprising, the Kaiser sample is a little bit more healthy than that in VA. Again, showing this Kaplan-Meier plot, very profound separation between the two. And again, using the 50% mortality cutoff, that for the people who had the lowest time in range, their mortality reached the 50 percentile, maybe about 8 years, whereas those who had the highest time in range actually did not reach the 50th percentile for survival, suggesting that there is a difference between these two. So when people don't have high time in range, as you can imagine, that means that they may be spending their time either above or below their range. And what are the impacts of that directionality? Are there differences? So using this hypothetical patient I've shown here that this individual has most of their A1Cs below 7. You might say it was good, but we'll see. So they spent maybe 2/3 of their time below range. And this is a hypothetical patient who spent most of their time above range. So what impacts might these have in terms of the risk for their adverse outcomes? And what we found, again, using these same samples, and we defined someone as being out of range or either below range or above range by whether or not they spent 60% or greater of their time, meaning they spent the predominance of their time in either their below or above range categories. And without going into detail, we also looked at other more modest amounts of time out of range. And if you compare their outcomes to the group that spent greater than 60% of their time in range, that being below range was associated with mortality, cardiovascular disease, and dementia. And being above range was associated with mortality, cardiovascular disease, and microvascular complications. And not surprising, maybe being below range was associated with fewer microvascular complications, given the well-established clinical trial evidence that glucose control maybe prevents some of those complications. But in fact, it came with its consequences. Also, interestingly, we were unable to see a relationship between being above range and dementia. Most of the risk was shown in the group that was below range. So it looks like directionality makes a difference, and below range clearly carries its consequences. All of these are observational data. And I think we have to have a great respect for the fact that these are not randomized clinical trials. And in fact, it may be really difficult to do an RCT of testing whether or not time in range actually makes a difference prospectively, although we're in the process of doing a trial emulation that might mimic an RCT to be able to address this. You're always left with the possibility that your data may be they may be confounded and not causal. There are lots of things that we can't control for, although try as we may. We can look at prescription refills, but we can't necessarily determine what medication adherence is. We have no eyes on patients' self-management behaviors. We can code for their comorbidities, but we can capture codes for comorbidities, but we're at the mercy of the clinicians who see those patients and whether or not they code for diagnoses. Older adults can be frail. That doesn't necessarily have a code associated with it. And there's also the potential for reverse causation, in that people who are sickest are the ones who have the time out of range because they're sick. And so they die earlier, and therefore it's not necessarily causal, but related to the underlying mechanism. What are some of the things that could explain this relationship? Well, there's a paucity of data that says that people who have wide swings in their glucose may actually have increased oxidative stress or inflammatory markers. It's been best shown in vitro, not necessarily well in vivo. There's obviously a concern about whether or not this may lead to endothelial dysfunction. Are these people at risk for hypoglycemia, whether occult or overt? And there's also a well-established phenomenon that people who have wide swings in their A1C, particularly rapid declines, may be at risk for exacerbation of microvascular complications, or maybe even macrovascular disease. Is that part of this? We're in the process of looking at that latter bit. I can't tell you about any of the former. These types of measures require EHR calculations. So deploying it, you have to basically embed this in your EHR. That's something that we're trying to work on in our dissemination and implementation. And then a question is, what can you do about it? Well, obviously, if you find it's a risk predictor, you may look for potential underlying causes for it. And then a question that we frequently get is this mitigated by access to newer medications such as SGLT2 inhibitors, GLP-1 receptor agonists, or even use of CGMs? And at this point, it's premature for me to say that because we don't have sufficient data to draw those conclusions. So as I wrap up, I want to leave you with this idea that optimal diabetes care is not just lowering glucose, that lowering glucose is a part of it, but not necessarily all that you want to do. And I'm reminded of the psychologist Maslow, who is famous for lots of other things, but he is also famous for saying, when all you have is a hammer, everything looks like a nail. So what I want you to be cautious about is the fact that we have these tools. You don't necessarily want to be married to them, and thinking broadly. And in fact, for those of you who are future investigators, this is an opportunity to be curious, to say, why? Why does this occur? Not necessarily this specific phenomenon, but to say, why do we accept the fact that these are observations? What else might be hidden behind them? And so Arthur Miller, the famous playwright who wrote Death of a Salesman, was also famous for saying to Willy Loman, man must shape his tools lest they shape him. So I invite you to develop your own tools that may actually help answer questions like this. So in summary, diabetes treatment goals, particularly in older adults, should be individualized. I think that's probably an accepted practice because complications and the benefits of treatment accrue over time. Those who are less likely to accrue those benefits don't necessarily need to have the tightest of control. That it's important because of that to engage in shared decision-making, that every individual should have an opportunity to participate. And it's important for us to educate ourselves when we're talking to patients about treatment goals, because of the fact that they may have very different perceptions of what they are to accrue in terms of benefits and what might be the risks that they would be exposed to. I've shown you data that both lower as well as higher A1C carries risks. It's unclear if use of newer medications or access to continuous glucose monitoring will mitigate these risks. And I've maybe given you a little teaser that glycemic variability over time is a risk predictor and that stability is associated with the lowest risk. So this work would not be possible without the series of collaborators that I've had the benefit of working with, and had the great fortune of being supported by the National Institutes of Health and the Department of Veterans Affairs in our research effort. And I believe there's one additional slide for you to scan the QR code to do an evaluation, right? Okay. So, I intentionally left a few minutes for discussion, and I welcome any comments that you may have. And Kelly's going to run with the mic.
Thank you. That was a great talk. Very interesting. So you got my attention when you introduced the concept of variability by quoting other physiologic systems, heart rate variability, for example. Heart rate, the absence of heart rate variability, unless I'm misremembering, is associated with increased mortality. Mm-hmm. So variability in biological systems, many biological systems, is actually correlated with beneficial outcomes. So my question to you is this glycemic control far out of range, or is it variability? If you have you looked at variability within a more, let's call it, normal range?
Mm. So thank you for saying about the heart rate variability. You're right, but there, in the converse, in blood pressure and weight variability, the actually standard deviations are associated with greater risk. We have not looked at within the normal range, but what we have looked at is standard deviation and coefficient of variation just as an indicator of variability per se. And it turns out that those are each associated with increased risk. So even if you look at variability independent of the mean, that there is increased risk associated with A1C variability. So I don't know if that addresses your point. But so independent of the mean, or even when stratified by different levels of mean A1C, that higher standard deviation or coefficient of variation carries increased risk. So there is something about variability per se.
So I'm going to ask a variation on the same theme. The Japanese use a measure that's commercially available, 1,5-N-hydroglucitol, as an intermediate measure of glucose control. But is there data in the Japanese literature that shows similar parallels to what you're seeing with A1C?
I have no knowledge of that. I've not seen that. Thank you. I can hear you. There you go.
Thank you. That was an excellent talk. My question has to do with attributable mortality. You convinced me that there are variabilities associated with mortality. I have a lot of patients with COPD who are admitted to the hospital for exacerbation and put on short course steroids. And I'm convinced they probably have a lot of A1C variability due to that, but their mortality could be due not so much to the diabetes, but as to the comorbidity that the steroids were applied for.
Mm-hmm. So these are some of the challenges you get when you're working with observational data, and that is that we would not be able to capture whether or not this person's A1C variability had an attributable cause. The only thing that we can do is to control for all of the comorbidities that exist in the EHR, and with the presumption that that person was coded for COPD, we would capture that. We also include in the analyses hospitalizations and other healthcare utilization. So for as much as we can, we control for it. The scenario you described is real, but I suspect it's probably not the majority of the cases of people that have wide swings in their A1C over time. And the presumption would be that that might be short-term variability and not longer-term variability, keeping in mind that the time of measurement is 3 years. Dr. Fonseca?
Thank you, Paul. That's very, very nice talk. And, I accept that variability is a problem, especially if you think of why is an individual varying a lot. Often it is adherence to therapy. There is a certain degree of seasonal variability in A1C across the population as well. It goes up over the holidays and then comes down in January when everybody goes to the gym.
Yep.
There are other factors that are very important when you're looking at it in populations, such as why is the A1C low in that low? And many of those people have renal disease, anemia, things that contribute greatly to mortality. At the other end, we have here from Louisiana, Jim Hempy at Children's Hospital described, and I've worked with him along with Stuart Chalou, looking at hemoglobin glycation as an indicator. It's actually very important. It's genetically determined. We've done GWAS studies showing that there's certain genes that determine for a fixed level of glucose. Some people have higher A1C, some have lower A1C, and it actually matters. And that can vary depending on what drugs you're taking, what comorbidities you have, how much inflammation you have, and we've published all this data.
Yeah, well, thank you for pointing those out. With regard to the different glycation index, obviously we can't control for that, although the presumption would be that that would carry with them regardless of what treatments they've received. It may affect the absolute level of their A1C, but not their variability. With regard to the other facts that people who may be low are low for a reason, absolutely. You cited just a few examples. There may be many, many others. The best we can do is to try to control for that through all of the variable collections and to be able to obviously put that into the model, but there are some variables that we just can't capture. And so we're left with that. And I will riff for just a second on it. And some people have argued that some of these data, because of the fact that they preceded a lot of the more frequent use of agents that don't have hypoglycemia as a risk, that maybe if you're using drugs that don't have hypoglycemia risk, that an A1C of 6.5 is just fine. I think that's a testable hypothesis, but not necessarily proven or accepted.
Yeah, I was wondering if age affects variability. Is there like a survivor index on variability so that as you get older, or the older people, you get older because you have less variability, and so that affects that variability?
So we're seeing a survivor effect. So we have actually applied these, although I didn't have a chance to show this, but we've looked at across the age spectrum in adults with diabetes from 18 years to 100. And the phenomenon exists even in people that are younger, so that albeit event rates are lower, that A1C variability predicts mortality across the age spectrum.
Paul, does variability play a role here in terms of Alzheimer's and continuing that aging sort of thought? And if so, or even in the dementia phase, are there mechanisms that you know of that are at play here?
The association with Alzheimer's disease and related dementias is really intriguing, and obviously we're hoping to explore it a little bit more. I'll come to your comment in just a second. The one caveat that I think needs to be put into place, and that is that we're diagnosing Alzheimer's disease based on codes in the medical record, and for many people that's a slow and gradual progression. And so the fact that someone ends up with a code today, they may have actually had the antecedents that go way back. And so legitimately what we're trying to do is to better understand how much of this is cause, effect, or reverse causation. If there is a cause and effect relationship, there's intriguing evidence about people who have diabetes and insulin resistance that may actually reside in the brain, and that as a result of that, their glucose uptake may in some way be impaired. And so in theory, if they have lower than appropriate glucose levels as measured by their A1C, that may in fact lead them to have less glucose uptake because they have this insulin resistance that prevents, and so there might be neuronal damage or starving, et cetera, as the case may be. You can see I'm using my hands and waving them a lot in explaining that. So all of which is conjecture.
Excellent presentation. Just wanted to follow up on variability and insulin resistance being the cause of that variability. Do these individuals who have variable require more or less insulin to regulate their glucose levels?
I'm sorry, I missed the.
So do the individuals who have much variability require more amount of insulin to regulate their glucose, or this is not reflective of insulin resistance?
So if I understand you correctly, is the variability related to insulin
resistance?
Insulin resistance. I can't tell you, only because of the fact we're obviously that would be a research-related measure, and we're using EHR-related data. Being respectful of the clock, we'll take one more question.
Thank you. This was an excellent talk, and I think individualizing is, we sort of got that message, which I'm excited about. My question is, I wonder if you've looked at specific sort of population with, I could think of renal population. So they're high risk. They may not belong into that sort of the way we divide expectancy maybe.
Mm-hmm.
And as we know that with renal disease, as it progresses, the A1C lowers,
Mm-hmm.
may not be low, but it's lower than maybe what they were before
Mm-hmm.
because of lack of clearance of insulin. Have you looked at maybe some of these low risk populations specifically, or high risk like renal?
So we've not looked at specific subgroups and partitioned the sample to see whether or not there may be unique characteristics. It's an intriguing thought to look at.
So I think all good things must come to an end. A round of applause for Paul.
Thank you.
I want to thank everybody for coming here. You must be curious to have come. You know, as you pointed out, you have some curiosity. And I want to point out another thing that Paul commented on as part of our LA CaTS thing, and which is very few clinicians going into research, which is not good. And so John, Dan, and I want to see more applicants for roadmap scholars from the physicians in this room and your friends. So please pass that on.